So welcome, have a look at this stomach, which looks maybe from first sight normal, but as you go up to it, it's kind of pretty much one large fundic cystic gland polyp. There are so many of these. They're everywhere, and you can see also what is quite striking is that there's a line against the antrum where you don't see any of these fundic polyps anymore. So let's do a proper stomach inspection and talk about how to do it. We get the stomach in a neutral position. It's quite important to know where the neutral position is, which is like this. Lesser curve at 3, greater curve at 9, come back to the junction. We're not focusing on the esophagus, but the gastroesophageal junction is quite an important place to image, and imaging it without a cap is quite difficult, as is demonstrated here. But imaging the stomach without a cap is quite useful because you get a more wide field of view, a wider field of view, maybe I can say. So if we come down, we'll push the scope into the curve and then gently advance into the antrum. We can start by ignoring the duodenum for a second. And this patient has FAP, familial adenomatous polyposis coli. And we want to talk about structured stomach inspection. So that involves for me a careful look in white light, and we're looking for areas of extra redness really. On the lens of this endoscope there's a little imperfection, which please ignore. But for the rest I think it's a really beautiful image, really high resolution image from this Fujifilm endoscope. So what you're looking for is extra redness. You're looking for any areas of depression, and I really think that you need to be structured about how you do these things. So pause the image for a start, because processing of a non-paused image, it's not so easy, or maybe it's just me, but I do think that you get more information by pausing. Have a look, think about it. Okay, I see nothing here. All right, then the next step is, okay, I'm going to go look closer, and maybe I'm going to use virtual chrome endoscopy. There are other detection modes, and so they are, this is Fujifilm endoscope, so linked color imaging mode, LCI. They exist for the other platforms as well. And the idea of this is that extra redness I was talking about in white light is more accentuated in these modes. And again, here we don't see anything, but maybe it's worth pausing to check that. Then the final thing is, well, actually, the other modes that you should be interested in is probably a characterization mode. So if you see something, this is useful. This is also useful when you get experience at it for looking for things, but it's not as useful, I would say, as white light or LCI, because these are detection modes. So you have to separate the detection modes of white light and LCI and characterization mode of BLI. What is characterization? That is when you see something, you go up to it, you pause the image, and you use the mode to interrogate the vascular pattern. So that is BLI is that kind of mode. And we'll come back to that in just a second. So then the question is, well, okay, I've looked in the antrum. I think it's fine. What do I do now? And what you do now is you take a structured set of images, and you take those images in a structured orientation, because if you don't take them in a structured orientation, when you come back the next time, how will you know if something was there or not? So either include a reference point, and then I think it doesn't matter, because if you can always relate, this is the incisoria up here at the 11 o'clock, 10 o'clock, and you can always relate that point to the pylorus in terms of the clock face orientation. But if you don't have that in the image and you just do it like this, and then maybe I'll just make a ridiculous rotation here to kind of make the point, this image, where is it? Where is the orientation? If I find something lesion here, if I want to take a picture of these polyps here, this is a useless image in terms of orientation unless you annotate it. And most people don't have the ability to annotate their endoscopic images, not in 2024, not without some AI device that's not released to the market yet. So I think you really need to either describe it, and that is get in clock face orientation. In the antrum, that is probably getting the incisura at kind of 12 o'clock type position, right? So if the incisura is at 12 o'clock, then you can clearly describe related to that in a clock face orientation around the pylorus. You can also say, okay, now at the 9 o'clock in this image is the greater curve, and if I want to describe something, the imperfection on the image is quite useful because I can use it as a pointer. So if I want to describe something where that imperfection on the image is, then this is greater curve antrum junction, for example. Okay, and then once you've done the photographs, and so let's just take some standardized ones for showing you how you should do it, and here we have it, so like this. And maybe you want to go in closer, maybe a little bit. Maybe you want to take a close-up of the pylorus. Maybe you want to come back and give a view of the part that is abutting the greater curve in white light. And maybe you also want to, and now it's the next part, get a photograph of the angulus. The angulus is poorly imaged. You need this sort of view. You need to distend the stomach, okay? And so you want to get this sort of view of the angulus. That includes the pylorus, so you know where you're talking about, and also probably one that includes the other side as well, so that you can see everything. Right, so we dealt with the antrum. Now we're talking about standardized photography. We didn't even get to biopsy yet. Photography of the rest of the stomach. So the main key problem here is that this stomach will be surveyed probably every 6 months. And the question is, well, what is changing? What is there? What is not there? What was there before? What is not there? Because what we know is that in FAP, these things we're looking for are not these fundate gland polyps. What we are looking for is flat cancers. And flat cancers are not easy to see, especially not easy to see when there are loads of other fundate gland polyps around. And so fundate cystic gland polyps, in this case, could be described as the trees making up the forest. And you are looking for a particularly low tree, a tree that's kind of on the forest floor, amongst a load of very tall trees in a forest. And that is not easy to do. It is especially not easy to do if you're not an expert. It is especially not easy to do if you don't have enough time to do the procedure. It is especially not easy to do if you don't have the correct endoscope for the procedure, right? Now, in this case, we have all optimal conditions. We have an endoscope which is high resolution. We have a very distendable stomach because the patient is under complete anesthesia. And we have someone who's at least done some of these procedures before. So, eye is drawn to this area up here. We'll ignore that because that's a cold snare polypectomy that one of my colleagues did before. But you can get the idea that let's use that, because that's a very interesting reference point. Let's use that as something we might have seen. I tell you what, we never saw that before I distended the stomach, right? So that CSP was not visible. Now we've got it distended up. We not only see the gastroesophageal junction, but we see everything around it. So we can pull the scope right up into the gastroesophageal junction. We can look for junctional lesions because patients with FAP definitely get junctional lesions. I personally have missed a cancer in this location before, and those eagle-eyed followers of Geeks will remember that that was detected by one of the visiting faculty at, I think, Geeks 1 or 2, and it was in this location, okay? So I had done the gastroscopy before. It wasn't there for me, but probably it was. It was just too small and I overlooked it. And here, this area is not able to be seen properly unless you properly distend. And of course, if the patient is awake and moving around, you've got no chance of seeing something subtle in this area. So you need to consider the appropriate use of anesthetic for patients where it is incredibly important to detect small lesions. And then you want to consistently image the rest of the stomach. So how do we do that? Well, we take standardized photography, so an overview shot, the shot up in the gastroesophageal junction, with always a reference point in, right? So you can clearly see the lower esophageal sphincter, and you can see the position of the greater and lesser curve. So in this case, you can clearly orientate the image. Again here, go right up into the fundus, distend it properly, remove any fluid, and here, if you need to remove this, it's pretty clear. So clear fluid, okay, but any other fluid, not. Then push the scope right in. And we describe this kind of spiral movement where as you come down, you kind of spiral the scope around to have a look at these lesions as you come down. And probably now we will want to do the same thing with a detection, another detection mode. So do the same thing with LCI. But what we're not looking for is fundate gland polyps. What we are looking for is either malformed fundate gland polyps that are too red, or we're looking for flat things that stick out because on the detection mode, they are hyperemic, right? That's what we're looking for. And so I don't know about you, but the only thing I see that's sticking out and is hyper red is Maria Eva's polypectomy defect, which is very beautiful. We'll come back to that in a minute. Okay, right? And again, we want some standardized photographs. And I do, if you can get a photograph which takes all this in one, then I think it's a very useful localization photograph later if you find something else. Okay, and then once we've done all that, anything that you find that is looking suspicious, you characterize. So you want to put a cap on for this. I'm not going to for the purposes of this demonstration video, but you can look at any of our videos to see the benefits of a cap in terms of imaging. you'll see it here as well, because I am not able to adequately image these things because it's moving and I can't maintain the focal length. I can do it a little bit, but I can't do it perfectly, right? So we can freeze this image. It's pretty blurry. You can see the live image in the bottom right. This is, for me, entirely also consistent with a fundic cystic gland polyp, but maybe it's a little different morphology to the standard one. And you can do that to any ones which stood out in your view. So this is a pretty classic fundic cystic polyp, etc., etc., okay? And those ones which you consider to be in any way abnormal, you can just remove them with cold snare polypectomy. But of course, don't remove something that's flat and ugly looking with cold snare polypectomy. Okay, and then finally, it's about biopsy. So we're not going to go into that. We have had multiple, actually, of these videos where biopsy has been discussed. But there are multiple protocols, and if you want to find out about them, you can come and watch the symposium, because one of the presentations, I'm pretty sure, will go into those biopsy protocols. But you should certainly obtain biopsies from anything focal that you find. So any focal flat thing that you think might be a cancer, biopsy it, please. Describe its location, photograph it, and discuss it, the photographs, and hopefully a video with an endoscopist who does resection in a multidisciplinary setting. And finally, you take, if you find nothing, you take random biopsies as per any of the protocols, Sydney, Cambridge, there are a few of the stomach. And the idea of this is probably outdated, to be honest, if you're good at endoscopic imaging, but sometimes this picks up something and sometimes it gives you an answer. And then finally, let's just have a look at what has already been done here. So there's been a cold snare polypectomy of one of the fundic polyps, and this fundic polyp was here, I guess. So we can interrogate the defect of the cold snare polypectomy. And this is how to do it. If you don't know how to do it, take the water jet, really expand it up, and then suction out the fluid that you get. And so a couple of things about this. One, you definitely can do cold snare polypectomy in the stomach. Two, this is a nice cold snare polypectomy defect. You have a nice area of completely removed mucosa, probably with some remaining lamina propria and muscularis mucosa, but that's the nature of cold snare polypectomy. Nice crisp margin and target removed. This bleeding in cold snare polypectomy does not need further treatment. Okay, so I don't detect anything else here that we should do anything about, and therefore we will perform a structured biopsy series. Thanks very much for watching, and I hope that this was useful, and I hope that you see this as something positive in terms of how to do a high quality gastroscopy, and that you come and see loads more about that from an amazing faculty next week. Thanks for watching.